we will just go ahead and let you know how grateful we are for all of your support. This project is a collaborative effort across so many of the great institutions of California, including the Stroke Awareness Foundation, the California Department of Public Health, the Los Angeles Department of Public Health, our biopharma partners, the California chapter of the American College of Cardiology has recently joined us, and our most recent foundation that's joined us is the Santa Clara Health Trust. So with that, I would like to let you know that you can get 2 CME credits for this, compliments of USC. And I also want to, if you could go to the next slide, Jenny, I'd like to let you know that we are increasingly collaborating with some of our federal partners, including the Centers for Disease Control and Million Hearts program. Million Hearts has invited me to be a founding member of the Hypertension Roundtable, along with several of our Right Care leaders. So I want to also acknowledge my original first co-founder was Warren Barnes, and he is not able to be with us today, but he set us on a great path as the chief lawyer for the state of California for decades, writing the major components of health law for the state and working with me on health reform. He also joined Dr. Kaplan and myself in launching our original pilot in San Diego. Dr. Warren Barnes is put us on the path of competing against disease and not each other. So this is a synthesis triangle of our promising interventions that we have been promoting for now over a decade together. It continues to evolve, but the core components of what we are about are not super complicated, and they're enduring. We need to activate the patient. We need to do proactive outreach through team-based care. We need to do as much as possible intensively out of the medical setting. And we need to use protocols, especially medication protocols, optimal medication therapy, which we'll be hearing much more about from Dr. David Maron later. So next slide, please. The Right Care Initiative uses data to inspire the health systems at a regional level and statewide through data, so they can see each other's data and always what Dr. Kaplan and I would hear when we would go see the medical groups in San Diego, the first area where we tried to work intensively on that triangle, is every single medical group, every single time says the data is wrong. And this data is a very wonderful resource for the state of California that doesn't exist in all states. But what we've been doing now for over a decade is driving the health systems to at least get the basics right, where we have data to ensure that cholesterol is controlled, blood pressure is controlled, and blood sugar is controlled. We've seen some ups and downs, but really pretty amazing progress over the decade or more that we've been working together. Next slide, please. I would like to introduce, if you're ready, Bob, can you shake your head? Yes? Yeah, so you can unmute yourself. So Bob Kaplan is our original principal investigator of our original National Heart, Lung, and Blood Institute grant that enabled us to start intensively in one place to do things that are simple to protect families and things that are a little bit more complex. So Bob Kaplan is, if you'd put his bio back up for a moment, please. Dr. Kaplan is not only a wonderful friend, colleague, and mentor, but he's also the former Associate Director of the National Institutes of Health. He is a professor at Stanford currently, and he has so many accolades. I won't go into it all, but he is one of the most highly published authors in the country and probably the world. He's also just a great person, and thank you, Bob, for recruiting Dr. David Goff to be with us today. Has he been able to join us?
Yes, he's waving. I can see.
Fantastic. Oh, okay, good. I'll work on my technology here. So with that, I just want to say thank you, Bob Kaplan. Thank you, Dr. Goff, Dr. Maron. We're going to have a wonderful session today. Thank you for all the participants that have signed on, and thank you to our wonderful digital native staff who are pre-meds who run the operations for this as they are getting health leadership training. So with that, thank you, Bob.
Hattie, it's a pleasure, and it's great to see everybody. My responsibility today is to introduce the Davids, and so we have David Goff from the National Heart, Lung, and Blood Institute, and David Maron from Stanford. And I wanted to just lead into this just briefly before I introduce David Goff to say that the Right Care Initiative in California, as Hattie's mentioned, has been around for a while, and we've been entertaining these discussions about, well, how do we get toward the end of this epidemic of cardiovascular disease and stroke in the United States and in California in particular. And so we actually, over the years, we've spent some time thinking about how do we reduce this burden for California, and what can we do to get there? We had originally planned to include our colleague Darwin Labarth, who currently is with Northwestern University and formerly was the Director of Cardiovascular Diseases at CDC, to join us, but because of some technical problems, he wasn't able to do it, but he's going to join us for our January session. And so, as a way of leading into the discussion both today and as we look forward to having Dr. Labarth with us in January, I wanted just to say a word about strategic planning. That Darwin, when he was at CDC, had worked on something called the Action Framework for a Comprehensive Public Health Strategy to prevent heart disease and stroke. And although this was done quite some time ago, the beginning of the current century, I still think it's one of the most important documents around, and we might get back to this discussion as we go through this today. But the document, first of all, involved collaboration between federal and state agencies. So it originated in the CDC, but it had participation from a lot of HHS agencies, including the NIH. It also had very widespread buy-in from all kinds of groups, the American Heart Association, the associations of state and local health officers, and there's just a very long list of these. And the document tried to take a very comprehensive view of, well, how do we attack this problem of the cardiovascular disease epidemic? And I think one of the most important pieces of this is that it looked at the things that we do very readily. For example, it looked at people who have end-stage heart disease, where the goal is really to improve their quality of life until the time of their deaths. And then below that, there's restoring function for people who have had cardiovascular events. And then a step below that is us dealing with events, with myocardial infarctions and stroke and so forth. And then we get into the prevention side. That is, how do we deal with risk factors? How do you deal with behavioral patterns that might result in risk factors? And then there's the other extreme, which is how do you prevent risk factors from occurring in the first place? And this document really lays out a very thoughtful strategy on how all that should come together. And so I want to use that as a way of introducing David Goff, because there were lots and lots of people over the course of lots and lots of years that worked on this national strategy. And there were a bunch of committees that got together and provided suggestions and advice. But those committees were chaired by our first speaker, David Goff. And David actually cycled through this and now has found himself in a position at the National Heart, Lung, and Blood Institute, where he's developing a national strategy and a national strategic plan for what we used to call the heart division at NHLBI, now called the Division of Cardiovascular Sciences. So let me tell you a little bit about David. David is a North Carolinian. He grew up there. He went all the way down to Duke to be an undergraduate student, and from Raleigh, from Winston, I want to say Raleigh, but it's
that's Durham.
Durham. I'm sorry,
Durham.
David. I'm sorry for
that's okay.
So from Durham, he moved all the way to Chapel Hill, where he attended medical school, and he did a residency in internal medicine at Baylor, and then he stayed on at Baylor and completed a PhD in epidemiology. And from there, David has gone on to a really remarkably strong career. He was the chair of epidemiology at Winston-Salem, also North Carolina. And then he left to become, I think, the founding dean and professor of epidemiology at the Colorado School of Public Health, very unique school of public health that uses resources of the state of Colorado. And then from there, he's gone on to be the director of cardiovascular sciences at the National Heart, Lung, and Blood Institute. David, as many of you know, has had a remarkably impressive career. So as a cardiovascular epidemiologist and scientist, he's had important roles in the big observational studies, MESA, IRIS, ERIC, and so forth. He's played an important role in the Cardia study. And then he has been involved in large, important clinical trials, ALL-HAT, ACCORD, SPRINT, and so forth. And so he knows both the observational studies side and the randomized clinical trial side. He's served on lots of the committees and chaired them. He's also been involved in the development of guidelines for cardiovascular interventions. And he is just a really good guy. I think that one of the things that all of the speakers today have in common is that we all love Lake Tahoe. And for many years, David directed the American Heart Association 10-day seminar on cardiovascular disease and stroke, where each summer we bring in a group of fellows, and David can remind us of the exact number. He keeps track of this, but now well over 1,000 fellows that have participated in the seminar. And they come together for a period of 10 working days, but really 2 weeks to investigate these issues in some detail. And it has become sort of a rite of passage for people that have become involved in cardiovascular epidemiology. And as part of that, of course, I've had the opportunity to get to know David because I'm older, so I had a chance to watch him grow up through the seminar, but also to watch his kids, Katie and Alex, grow up into productive and important adults. So with all of that, David, thanks for joining us, and we look forward to hearing about what's happening with the strategic plan at NHLBI.
Well, thank you, Bob. I hope everybody can hear me well. I've had technical problems with my headset over the past couple of months, but hopefully it's all coming through. Since you mentioned Lake Tahoe,
Yes.
I thought I'd throw up this virtual background, which is sunrise over Lake Tahoe as viewed from Eagle Rock on the west shore, looking out over the Carson Range into Nevada. So it's a beautiful place. One of my happy places. So thank you, Bob, for those kind words. Really appreciate the opportunity to speak with this group, because what you're doing is critically important to addressing the leading cause of death on the planet. Now, it's just this planet, but that ought to count for something, right? So and you guys are focused on it, and that's fantastic. So I was asked to speak a little bit about our strategic vision. So I'm going to try to share my screen. Hopefully this is working too. And get it into a slideshow format. Hopefully that's working too. All right, I see the thumbs up from Hattie, so great. So as Bob knows, now that I'm at NIH, even though I'm speaking about what we're doing at NIH, I have to start by saying these are my opinions and views and don't necessarily represent the official views of the NHLBI, the NIH, the Department of Health and Human Services, and the US federal government. So with that out of the way, I want to talk a little bit about implementing our strategic vision in the Division of Cardiovascular Sciences. So when my boss, Dr. Gary Gibbons, got to NHLBI now, 7-8 years ago, he launched on a process of developing a new strategic vision, which is a good thing for a new leader to come in and to do early on. And that strategic vision document was published in 2016. You can download it from our website. It's really helpful if you're having trouble going to sleep at night. It's got 4 overarching goals that are shown here: understanding human biology, reducing human disease, advancing translational research, and developing workforce and resources. And those probably sound a little bit generic, as you might expect for an institute that has heart, lung, blood, sleep, and implementation science in its mission. And it has 8 strategic objectives. I'm not going to read them, but you'll have these slides so that you can refer to them at your leisure. And again, these strategic objectives are somewhat non-specific for heart or lung or blood. And underneath these 8 objectives, there were over 100 critical challenges and compelling questions that were submitted from the investigative community. And one of the really nice things about this document is that it was created through a process of crowdsourcing in which thousands of scientists from around the country and indeed around the world put input into the process. And then that process was bubbled up. People voted on ideas, commented on ideas. The product was synthesized. And so it wasn't a bunch of bureaucrats in Bethesda telling you what we think's important. It was you telling us, or you telling each other, what we all think is important. And so that's really cool. But that was a strategic vision, and it's said that a vision without a plan is just a daydream, but a plan without vision is a nightmare. So we started with this vision. And we've moved. When I got to NHLBI in 2016, Gary asked me to develop an implementation plan for the division so that we would have a plan to implement the strategic vision, not just a daydream. And so we started with deciding what our mission statement was, and that was pretty easy. We said turning discovery into cardiovascular health, and that's taking the NIH tagline, turning discovery into health, and just plopping the word cardiovascular in it. So we said that job's done, and now we can move on. And we did a landscape analysis to see where our current investments were and what the opportunities might be for the future. And I encouraged the team of folks in our division to think big. There's this saying by an architect from Chicago, his last name is Burnham, and it goes something like, make no small plans for they have no magic to stir men's passions, and in the end they themselves may not be implemented, so make no small plans. So we wanted to make big plans where we could potentially lead to breakthroughs rather than incremental advances, which we think are occurring all the time through the investigator-initiated grants that we support. So we were looking for opportunities to make bigger bets, some of which will work, some of which will not work. And we needed to understand the scenario that we were facing as a country. So we looked at recent and current status of cardiovascular disease. And this is a busy slide, but I'm only going to make a couple of points. And that is that by 2016, it was very clear that we had entered a period of recent stagnation in cardiovascular disease in the United States. After decades of improvement, decades of decline in cardiovascular disease mortality, about a 70% decline in cardiovascular disease mortality between the mid-1960s and about 2010. But by the middle of the last decade, it was clear we'd entered a period of stagnation. And that's shown in the panel on the left. This was really disappointing because we had been looking forward to dipping down below cancer and having a we're number 2 party, because we had been number 1 cause of death in the country for so long. We got right down to cancer and then just stopped and have stayed higher than cancer. In addition to recent stagnation, we've had enduring disparities. So the middle panel shows you those disparities by race, ethnicity in the US for both ischemic heart disease and heart failure. You also see a couple things there where ischemic heart disease mortality has continued to come down, but heart failure mortality has started to trend up in the past decade. And another enduring disparity has been by geography in the United States. Maybe a little bit hard for you to read the legend, and legends are important. So I want to point out that the red counties, this is county level cardiovascular disease mortality. The reddest counties have a annual mortality rate of about 400 to 500 deaths per 100,000 population per year. And the lowest counties in the blue are around 75 to 100 cardiovascular deaths per 100,000 per year. This is a range that's 4 to 5-fold at the county level in the United States. This is not comparing low-income countries with wealthy countries. This is comparing counties in our country where the range in cardiovascular disease mortality is 4 to 5-fold. This really should be viewed as a national disgrace. Okay, I don't think that's overstating the challenge of cardiovascular disease mortality in the United States. And what you can see is that the heartland, the Ohio and Mississippi River valleys, stretching out to Oklahoma, that's where the highest cardiovascular disease mortality rates are in the country. So with that as the landscape, the idea that we should make big plans, we should be looking for things where we can make a big difference, and we have important work to do. We stimulated another round of crowdsourcing to get ideas from the community and to synthesize those ideas. And we came up with 6 pillars for our strategic vision implementation plan. And this plan, at least a high-level summary of it, was published last year in Circulation Research. And these were the 6 pillars. Addressing social determinants of cardiovascular health and health inequities. That's that very upstream part that Bob was mentioning from the Public Health Action Plan to prevent heart disease and stroke. Enhancing resilience, the concept that some people, despite being in an adverse environment or having adverse behaviors, tend to do well. You've probably all heard the story of my aunt or uncle who smokes packed cigarettes every day and died of old age in their 90s or 100, never had a problem. Some people seem more resilient than others. Could we learn about resilience and harness that knowledge to help others? Promoting cardiovascular health across the lifespan, I used to say from the womb to the tomb, but then I heard Cheryl Anderson the other day say from the twinkle to the wrinkle, and that sounds a little bit nicer. So I'm going to start saying from the twinkle to the wrinkle. And after I give her credit 2 or 3 times, I'll stop that and just claim it as mine. Then we had 3 more disease-focused areas: eliminating hypertension-related cardiovascular disease, reducing the burden of heart failure with focus on heart failure with preserved ejection fraction, and preventing vascular dementia, a problem that we're just not at all prepared for. I'm going to speak a little bit about 4 of these areas and then close at the end, talk a little bit about what we're doing with the COVID pandemic, because it seems like everything is about the pandemic these days. Please put questions or comments in the chat box, and we'll try to get to them as they come along. So addressing social determinants of cardiovascular health and health equity is really important. And I touched on this before. This is the same map I showed you before. And we have a major initiative that we just launched in collaboration with another component of the Institute that we call CITRIS. CITRIS stands for the Center for Translation Research and Implementation Science. It's led by Dr. George Mensah, who's also well known to many of you. And we, in collaboration, put out an initiative called Decipher. We love our acronyms. And Decipher stands for Disparities Elimination through Coordinated Interventions to Prevent and Control Heart and Lung Disease Risk. The focus here was on identifying high burden communities, creating academic community partnerships, using health metrics, and focusing on testing innovative strategies to implement evidence-based solutions to improve the use of evidence-based care. So for example, an idea could be in hypertension control, building on the great work that Ron Victor did in the barbershop study. Can that be disseminated? Effectiveness has been shown. What about the dissemination potential? That would just be the kind of idea that might fit in. We've made 7 awards plus a coordinating center. I'm not going to read all this, but I did want to point out that 3 of the awards focus on hypertension, which is really important given that hypertension is another pillar in our strategic vision implementation plan. So we were really pleased to see hypertension play a major role in this initiative. We've also had a number of workshops. One of the things we do at NHLBI, oh, I see a hand. Can you speak, Hattie? Maybe take yourself off.
Your slides are not moving or advancing.
Okay, sometimes that happens on Zoom. So I'm going to stop my, which slide is it frozen on?
Sustaining DCVS leadership.
Oh, that's been a while. Okay, sorry. So I've stopped my video and that usually helps. I'm going to stop sharing my screen and then try again. And what usually happens at this time is you see a black rectangle that says I'm trying to share my screen. So tell me when it's back up again.
It is back up and it's flipping back and forth, so it's probably working.
So do you see addressing social determinants of cardiovascular health equity, Decipher?
Yes.
Yes.
Wonderful, thank you. So so that's the slide when I was talking about the project. This is the slide that has the projects that were funded, 3 of which have asterisks by them that are related to hypertension that we're very pleased about. We're pleased about all of them. And I mentioned that we've had several workshops focused on social determinants of cardiovascular health. You'll have this slide and you have the links to those reports that are posted on our website. One of the things we do to implement our strategic vision is bring in experts from the research community to give us input on opportunities for on research opportunities, generate new knowledge that will help address the specific issues. And so these are the sorts of workshops we've been having on social determinants of cardiovascular health. And most recently, let's see, here we go. Most recently, we've had a strategic visioning session with our advisory council and our board of external experts to talk about social determinants of heart, lung, blood, and sleep health and health disparities across that spectrum, really at the institute level. I like to think that our focus on this within the Division of Cardiovascular Sciences got the attention of everybody at Heart, Lung, and Blood Institute, but also, frankly, the things that have been happening in the country over the past few months also contributed to that attention. And we had a recent strategic visioning session with our entire advisory council who gave us some input on things they think we should be doing to advance heart, lung, blood, and sleep health equity through research. And some of those ideas are shown on this slide. I want to transition to our efforts on preventing cardiovascular disease, promoting cardiovascular health across the lifespan. Early on, we asked a team of staff to do a portfolio analysis to see where were the weaker parts of our portfolio. And it didn't take long to determine that we had a lot of work going on with older populations. And by older, it'll be younger than me. From middle age and on, we have a lot of data from our cohort studies and our clinical trials, but we had very little data on cardiovascular health in children, adolescents, even young adults. And so the initial focus of this group on promoting cardiovascular health across the lifespan has been focused on younger ages. Toward that end, we've also had a number of workshops. And again, I would call your attention to our website where we have these workshop reports posted. But I really want to draw your attention to the last thing here, because this is really exciting from my perspective. We recently published a notice of intent to publish a funding opportunity announcement for an initiative that we're calling ENRICH. I said earlier, we love our acronyms. Early intervention to promote cardiovascular health of mothers and children. So this is a program that we envision working to test strategies to intervene with young mothers and their children to promote cardiovascular health in partnership with home visitation programs. As one example, HRSA runs or funds a series of home visitation programs across the country that serve low-income women. Most of them identify these women during pregnancy, some shortly after delivery or at the time of delivery, and provide services that focus on parenting skills, early childhood health, preparedness for school, these sorts of issues. And there really hasn't been a focus within these programs on identifying women in poor cardiovascular health and intervening to improve their cardiovascular health or the cardiovascular health of the child. So we're really interested in testing whether this platform that already exists, it's already in all 50 states and in DC and in tribal communities, whether this platform can be used to deliver a behaviorally sound cardiovascular health promotion intervention. So stay tuned for that, or if you're interested, take a look at it and apply for it when the FOA comes out. We're also have several other things going on in this space. We have put out a NOC, which is a notice of special interest, that we're very interested in understanding factors in infancy and early childhood that influence obesity development and cardiovascular health development. And we're partnering with the National Institute on Environmental Health Sciences on the children's and now human health exposure analysis resource to understand environmental impact on cardiovascular health. And we know the environment, the chemical environment in particular, has an impact on health. And often this is distributed socially in a way in which lower income communities are more exposed to environmental pollution. And we're also collaborating with NIDA on the adolescent brain and cognitive development study, a study of about 10,000 9 and 10-year-olds when the study started, looking primarily at brain development, but we're adding some heart, lung, blood, and sleep measures. So really excited about those efforts as well. Efforts that we hope will end up with improving cardiovascular health in children. A little bit about hypertension. We're very interested in hypertension. I've of course have personal interest in it, but also hypertension is, according to the Global Burden of Disease Collaboration, the leading cause of death and disability on our planet. So that's important. The Surgeon General recently put out a call to action on hypertension, and these are the pillars of his call to action: prioritize control nationally, cultivate community support, and optimizing patient care. We have research activities going on that are relevant to all of these things. We support research on testing new ways to treat hypertension in clinical practice, to improve hypertension care in clinical practice, quality improvement research. We support research on taking hypertension care to people outside the clinical setting. For example, the barbershop study that I mentioned earlier that Ron Victor did there in California, San Diego. Implementing evidence-based care in the community. I mentioned our Decipher program. We also do work on educating the public and setting the research agenda through workshops. We just had a workshop with CDC and the Office of the Surgeon General on hypertension control just last month. These are some of the high-level ideas that came out. The workshop report's not available yet because the workshop just happened in October. But some of the ideas focused on issues around achieving healthy behaviors, managing chronic conditions in the healthcare system, and engaging patients. These are things that I'm sure sound very familiar to the Right Care initiative. None of this is a surprise. I see Hattie nodding her head. I mean, these are issues we still grapple with and we think are still important to try to figure out how to do more effectively. So moving on to heart failure. You know, we want to move from heart failure to heart healthy, and that's good, but we face a lot of problems with heart failure, and especially heart failure with preserved ejection fraction, the type when the heart doesn't relax well, seems to pump pretty well, but doesn't relax well. So, you know, there are a lot of people in the US with heart failure. About half of them have HFPEF. It's projected to continue to increase, and there are major disparities with major burden in the Black population and the Latinx population. And especially HFPEF, there are diagnostic limitations. We don't really have a good biomarker. We don't have a lot of research that's charted the way forward, and many of the trials that we've done have tried to recycle medications that worked for heart failure with reduced ejection fraction and have shown that they don't really work with heart failure for preserved ejection fraction, which suggests we don't really understand the condition well, and we need to go back to basics. And for an epidemiologist, yeah, that means basic science even. So there is some work coming out, and some recent work suggests that HFpEF is a more inflammatory condition than HFrEF. That's this little chart down here where the green bars represent proteins that are in higher concentration in HFpEF patients, and the red bars, those proteins that are in higher concentration in HFrEF patients. This gives us some reason to think HFpEF is different, shouldn't necessarily respond to the same therapies. But even then, HFpEF is a really kind of wastebasket term. It's a syndrome, not a description of an underlying pathobiology. And so findings have come out to suggest that there are important different subgroups of HFpEF. This work from Sanjeev Shah shows 3 different phenogroups in his clinic that he's described with different labels. They're all 3 relatively large groups, and they have much different outcomes, as you see on the right, in terms of survival free of hospitalization or death. Phenogroup 3, which is the one that has right ventricular failure and cardiorenal disease, that's a very poor prognosis. And the one on phenogroup 1, which is described as BMP deficient, has a much better prognosis. So this gives us some idea that we need to subphenotype HFpEF so that we can do a better job of finding the pathobiology that underlies HFpEF, identifying the potential therapeutic targets, and supporting drug development so that we can be successful in treating HFpEF. Of course, we'd also like to prevent it, and some of this research may give us directions on how to do that as well. We've recently launched an initiative that we're calling HeartShare. The Institute has invested $25 million in this initiative over the next 5 years, where we're going to be funding some retrospective analysis of existing data, as well as funding new cohorts of HFpEF patients and comparator participants so that we can do deep phenotyping, so that we can do subgroup identification, disease deconstruction, target identification to support drug development efforts. This will all be in the pre-competitive space, so we're also working to partner with industry to get them on board. I was just on a call with representatives from 11 different drug and device manufacturers this morning that have agreed to join us in a planning phase so that we can develop a private-public partnership to leverage the resources we're putting on the table to bring industry resources and expertise to bear so that we can really make an impact on HFPEF. And we're just very excited about this. This is probably the largest unmet need in clinical cardiology today, is what to do about HFPEF. Certainly if you talk to practicing cardiologists, you'll hear a lot about this. Now, you know, as a preventive cardiologist, I might say, well, preventing hypertension is the biggest thing because that might prevent a lot of this before it even gets there. So, you know, beauty's in the eye of the beholder. This is a really important part of our initiatives going forward. I want to turn our attention just a little bit to COVID in the last couple of minutes because the pandemic has changed everyone's life. I'm speaking to you from, you know, the second bedroom in my condo. I haven't been into the office since March 13th because we've been on extended telework since March 13th. So clearly the pandemic has changed a lot for a lot of us. And at NHLBI, we've been doing our part to rise to this challenge. It's clear that COVID has a major impact on the conditions of interest to us. There is evidence of cardiovascular complications, myocardial involvement, myocarditis, perhaps some heart failure as well. Clearly, the lung involvement is just devastating for some individuals. Coagulopathy, which probably represents an underlying vasculopathy or vasculitis or endotheliitis. This is something we're very interested in. And then we're also hearing about a lot of insomnia and sleep disturbances in COVID-19, and it's affecting our country in ways that you know very well. And those people who have chronic conditions and heart, lung, blood diseases seem to be at increased risk for adverse outcomes. So this is a double whammy for our mission. So we've been trying to rise to this occasion and do our part to meet this national and international challenge by supporting studies that would be focused on identifying host-directed therapies, by funding observational longitudinal studies, translational preclinical studies, data resources and platforms to make data available to the research community, and to do community engaged research to partner with the target populations that are most severely affected by COVID. And these are some of the goals of our COVID related activities. We have some specific projects that are up and running across this range of clinical conditions. So in the pre-hospital outpatient setting, the hospital setting, and the post-hospital convalescent patients, we have a variety of trials ongoing. We're testing anti-thrombotic strategies across the entire spectrum. We're testing passive immunity with convalescent plasma and monoclonal antibodies in the pre-hospital and hospital setting. And we're testing anti-inflammatory agents both in the pre-hospital and hospital setting. In fact, our study of hydroxychloroquine was begun back in March. We got it launched in April. We got it completed. It was either by the end of April or mid-May. And the results are out. And of course, they showed that hydroxychloroquine was not effective, but we were able to really put a definite answer on this question very early. And this was related to the strong work of our lung division and their pedal network that has focused on ARDS and pneumonia. And then we have observational studies that are looking at understanding disease pathobiology and risk and long-term outcomes and some of the post-acute sequelae of COVID, the so-called long haul condition. We're doing this through an effort that we're calling CONNECTS. We love our acronyms. Collaborating Network of Networks for Evaluating COVID-19 and Therapeutic Strategies. And we have brought all our clinical trials networks and our cohort studies together to work together, all hands on deck. Some of these networks are heart related, some are lung related, some are blood related. They have all pitched in to address this international challenge. And this map that I'm showing you, every dot on that map is real. That's a real site where we have real resources on the ground that are really helping us address this issue. And we just couldn't be more pleased. You'll see a lot of dots out here in California. A lot of you and your colleagues are helping us with this effort. We're also involved in COVID-related research in children. So you've probably heard about and read about, maybe you're taking care of children who have multi-system inflammatory syndrome or MISC. We're co-leading this effort with the National Institute of Child Health and Development to understand MISC, how often it occurs, why it occurs, how can we treat it, how can we prevent it. So that's another major effort we have going on in COVID. And finally, we're working diligently to engage and work with communities with disproportionate burden. This slide shows you in particular that Hispanic, Latino, non-Hispanic American Indian or Alaska Native and non-Hispanic Black populations have much higher age-adjusted COVID hospitalization rates. They also have higher mortality rates, and yet we know these communities have significant distrust with the biomedical research community for good reason, and that they are unlikely or less likely to participate in research unless we make special efforts to reach out to them. So we have initiated a program called SEAL, Community Engagement Alliance Against COVID-19 Disparities. We're co-leading with the National Institute on Minority Health and Health Disparities to engage the community, to address misinformation and mistrust, to promote and facilitate inclusion of diverse populations in clinical trials, including vaccine trials and therapeutic trials, targeting populations that have been disproportionately affected. And we've made 11 awards to 11 states that you see with stars on this slide. The goal is to establish partnerships within the community to address misinformation, to foster an understanding and trust in science, and to accelerate inclusive participation and uptake of beneficial treatments. So another initiative we're really excited about. You know, you may have seen this story in the New York Times titled, "I won't be used as a guinea pig for white people." And this is a real quote from people living in the community who are very distrustful of the biomedical research community. So we're trying to tackle this head on, address it proactively, and really engage these communities. And with that, I thank you for your attention. I hope this was helpful information to share and look forward to the discussion that will follow.
Thank you so much, David. And so we have just a brief time, about 10 minutes for questions now, and then we actually have reserved a long time for general open discussion after Dr. Maron's presentation and Dr. Bommer's comments. But since we have 10 minutes, and I thought, David, I would take the chair's prerogative and ask you this question. I had come across a poem, maybe you've heard it, from a Dr. Joseph Malins, and it was published in the North Carolina Medical Journal in 1895. And Dr. Malins was concerned because that there was an area in North Carolina where people were falling off a cliff, and that he raises this question: should we put a fence around the edge of the cliff or an ambulance down in the valley? And that the concern is that when outsiders look at the NHLBI portfolio, they see it as actually all about spending more and putting more ambulances down in the valley. And that I was intrigued by a paper that came out in JAMA last year from the NIH Office of Disease Prevention, which argued that when you analyze the NHLBI portfolio, or the NIH portfolio in general, that what you find is that there's actually not a proportionate share of resources that are being devoted to risk factors, and in particular interventions for risk factors. So I was just curious, David, have you heard this poem?
Bob is trolling me because I read this poem every year at the 10-day seminar and have been doing so for, gosh, the past 22 years or so. So I could probably almost recite it from memory, but don't challenge me to that because I'm sure I'd mess up. You know, this is absolutely true, that a lot of the resources, I mean, if you ask me where the resources go at NIH, and I certainly have a better handle on NHLBI, but I think this is true for NIH, most of the resources go into basic science. Now, some of that basic science will help us learn more about things that translate into prevention. Some of that basic science helps us learn more about things that translate into treatment. So basic science is important, but a lot, you know, we want to make sure that the basic science translates into health. I mean, this idea of turning discovery into health is really important. And so we focused on turning discovery into cardiovascular health. And in our strategic vision implementation plan, you know, two of the pillars are very much focused on this concept. There's addressing social determinants of cardiovascular health and health equity. You know, we want to invest in strategic initiatives that really move the needle there, and then promoting cardiovascular health across the lifespan. This is also about prevention. Both of those initiatives very strongly focused on prevention. Then when we get to some of the other pillars, initially, when we were doing this, and I was encouraging people to think big, we used this program for crowdsourcing, and I seeded an idea into it so people would be thinking big, and my idea was eliminating hypertension. Well, some people took a big breath and said, "What, eliminating hypertension? You know, what's your timeline on that?" And so we ended up agreeing on eliminating hypertension-related cardiovascular disease, which to me is a bit of a step back. I think eliminating hypertension really ought to be, you know, where we're focused. But you know, this is not a top-down driven strategic vision implementation plan. It's a group effort. But I agree with you. We need more effort on prevention research, on implementation science, on implementing effective strategies, so that we don't just turn discovery into publications in peer-reviewed journals, but we turn discovery into health.
Great. Thanks, David. Yeah, we just have a couple more minutes before we go on to Dr. Maron's presentation. I don't see any questions in the chat box.
How about if I ask one then? One of the things that we have a great difficulty with, Dr. Goff, is we often have the question come up, what is the right protocol for the difficult to treat hypertensive patient? And that is a scientific issue that we need to get beyond blaming the patient and start getting serious about our medication protocols and coaching. So I'd love to hear you elaborate on that a little bit.
Well, I'm no longer taking care of patients, but I used to. And so, you know, I'll comment, but there are people on this call who have a lot more recent experience in caring for patients than I do. I think one of the challenges in hypertension care is that the body has a lot of kind of counter-regulatory processes that kick in. So, you know, for example, when you give a diuretic, you know, the body can respond by vasoconstriction to keep that blood pressure set point. And so if you give a vasodilator, the body can respond by holding on to sodium to keep, you know, blood volume higher. And so it's often, I think one of the things we've learned is that combination therapy with medications that address multiple mechanisms is really important to try to keep you know, from a system biology perspective, you poke the system here and it adjusts somewhere else. And so you've got to be poking the system from multiple places when people have hypertension in order to be effective. So we've supported studies that have used combination therapies. We have a trial we're supporting right now that's testing a 4-drug low-dose combination pill. Yeah, 4 drugs and low dose in one combination. It's called the Quartet trial. I don't recall all the details of it as I sit here, but that's the sort of thing where we think that using very low doses of multiple different medications that have different mechanisms of action may help get blood pressure down with fewer side effects and with better efficacy. So in some of our clinical trials, like Accord and Sprint, we've been very purposeful about that, and we have given advice. We haven't dictated, but we've given advice to the clinics that were involved in the strategy we think they should use. Start with an ACE inhibitor or an ARB if the person coughs, add a diuretic, add a calcium channel blocker. That's the rational first 3 medications that we think make sense. Most people can be controlled with those 3 medications, either an ACE or an ARB, a diuretic, and a calcium channel blocker. It's not all that often that you need to go to a 4th drug, but you know, sometimes.
Well, thank you, David. So it's just about 1 o'clock here, 4 o'clock for you, David. So we should probably go on to David too. And we will come back for a more extended question and answer period later. So all of you out there, please be thinking about the questions you'd like to bring up. So let me see,
I apologize. So we have Dr. Balmer's bio up, and Dr. Balmer is not speaking now. Dr. David Maron is speaking now. Jenny, would you please put Dr. Maron's bio up on the screen?
And let me just
thank you.
Let me just briefly run through Dr. Maron's bio. So David Maron is the director of preventive cardiology at Stanford. He's someone who keeps returning to Stanford. He was an undergraduate there, and then he, after he completed his undergraduate degree, went off to medical school at USC. And from USC, he came all the way across town to UCLA, where he completed an internal medicine residency. And then he came back to Stanford and did a cardiology fellowship and a fellowship in preventive cardiology. And then he was a Robert Wood Johnson clinical scholar. And then he disappeared again and went off to Vanderbilt, where he spent 20 years before coming back to Stanford again in 2014. David is really the quintessential preventive cardiology clinician. But in addition to that, he has had extensive involvement in large clinical trials, in particular, the Courage trial, which, as he'll mention today, produced a result that was, I think, surprising to many cardiologists or interventional cardiologists at the time. And then he followed that up by being the co-chair of the NHLBI ISCHEMIA trial, which has been releasing results over the last year or a little bit more. And he is the co-chair of the ISCHEMIA CHD trial. David is just a delightful colleague, and I know he's the one who everybody sends their friends and family to for preventive cardiology consults. So David, it's great to have you with us.
Thank you very much, Bob. And I'll share my screen. And go into the presentation mode. And as I do, I would like to say that I did attend the 10-day Tahoe seminar, but it was before the time of David Goff. And so I'm sorry that I missed meeting you there. And this ischemia trial, as you mentioned, Bob, was funded by NHLBI, and I have just eternal gratitude to NHLBI for funding it, and hope that it'll provide guidance for the management of patients with stable coronary disease for a long time to come. So my disclosures, are that grant and that I'm a preventive cardiologist and not an interventionalist. I'll go through the background of strategy trials for patients with stable coronary disease, and then review the design of ischemia, what we found, and my own personal ideas about what it means for the way we should practice. This slide comes from a meta-analysis that Salim Yusuf published in 1994 of several bypass surgery trials. On the x-axis at the bottom is the extension of life from patients randomized to bypass surgery as compared with no bypass surgery. And these are various subgroups. And what you see is about, for patients with 3 vessel disease, about a 6-month extension of life. For people with left main disease, a little more than 1.5 years on average life extension. And for people with a reduced ejection fraction, an extended lifespan. And you'll notice for, pretty much everybody at this meeting today knows that we need to send people with left main disease for revascularization and for bypass surgery. That's what our guidelines say. It's based on 150 patients that were randomized. These findings, 3 vessel disease, left main disease, made it into our guidelines and have been there for many years. The relevance of these findings is a little unclear because, as I said, this was bypass surgery versus no bypass surgery. It wasn't really bypass surgery versus medical therapy that's disease modifying. But then in the era of medical therapy with statins and knowing that antiplatelet therapy helps prevent events for secondary prevention, there were 3 trials. You mentioned Courage, which I had a chance to help design and help lead, and then Berry 2D and FAME 2. So the Courage trial randomized about 2,300 patients with stable coronary disease to either PCI plus optimal medical therapy or optimal medical therapy alone. These were patients who had been referred to the cath lab for clinical indications, and they were not randomized until their angiogram was performed, and we knew that the patient qualified based on their anatomy and had at least a 70% stenosis. The primary endpoint was death or MI, and here were the primary, here was the primary outcome. And as you can see, there was no significant difference between the medical therapy and the PCI groups. And one of the first things I did when I got these results is I got a Kevlar vest to protect myself from irate colleagues who just did not believe the results of the trial and thought that it was highly biased. And then, we showed a quality of life benefit for patients who were randomized to PCI. The PCI group is in the dark bar and the medical therapy group in the light. And this shows the percent free from angina at various time points. These are months on the x-axis. And you can see that there was a significant benefit to the PCI group that shrank until, and it was statistically significant until 3 years, when there was no significant difference between groups. We did a long-term follow-up of the Courage trial to see if there was some long-term benefit of revascularization with PCI that we had missed. And there was not. There was no significant difference in survival. A couple of years after Courage was published came Berry 2D, funded by NHLBI. This was similar to Courage in that it included patients with stable coronary disease, but all of them had diabetes. And bypass surgery was one of the revascularization options. Again, patients were randomized after cardiac catheterization. The primary endpoint was all-cause death. And you can see here that there was absolutely no difference in survival between the group that was randomized to revascularization with CABG or PCI versus medical therapy as the initial therapy. And then came FAME2. And FAME2, again, stable coronary disease patients who, all of whom had an angiogram prior to randomization. And the patients who were selected had fractional flow reserve guided PCI plus medical therapy versus medical therapy alone. The group that had normal FFR served as a registry or control group follow-up. The primary endpoint was death, MI, or urgent revascularization. So death and MI are pretty hard endpoints, and then this softer endpoint of urgent revascularization. This slide shows the primary outcome with those randomized to medical therapy in red, to PCI plus medical therapy in blue, and the green registry group. And you can see there was a big difference. Many more events in the medical therapy group. However, those events were all due to urgent revascularization. There was no difference in death, no difference in MI between the medical therapy and the PCI groups. A 5-year follow-up from FAME2 again showed no significant difference in death or MI. So that primary endpoint was really all driven by urgent revascularization. However, when the investigators looked at the rate of spontaneous MI during the follow-up for 5 years, there was a significant increase and higher event rate in the medical therapy group versus PCI. The confidence limits for the hazard ratio just included 1. And so the New England Journal of Medicine didn't call it statistically significant, but there was a clear trend towards fewer spontaneous MIs in the PCI group. So there were some limitations to these previous trials. They included patients with all levels of ischemia. The revascularization procedures, specifically PCI in COURAGE and BARRY-2D, did not include many patients with drug-eluting stents because they just weren't available when the trials were performed, and no FFR was performed to select the patients. All of the patients were randomized after cardiac catheterization, so there was referral bias. We just know anecdotally that some patients were not included because their physicians wouldn't permit them to participate in the trial because of the severity of their anatomy. They thought they were too high risk to take the chance of being randomized to no revascularization. And FAME2 had a very small sample size and short period of follow-up. Our colleagues down at Cedars-Sinai had, in the meantime, published a very interesting observation. This is observational data only from their registry, from their nuclear stress test core lab. And it showed the risk of dying from cardiovascular causes among patients with varying levels of ischemia. On the x-axis is the percent ischemia on the SPECT, on the nuclear stress test, and on the y-axis, the risk of cardiac death. And below about 10% ischemia, there was a higher risk of cardiac death in the patients who were referred for revascularization compared with patients who were not referred. And then above 10%, you see this separation of higher risk of cardiac death in patients who did not undergo revascularization. Again, they didn't really, we don't know about their medical therapy, but based on secular trends, we don't think that their medical therapy was optimized. So this led to the research question for ischemia. What is the best initial management strategy for patients with stable coronary disease and at least moderate ischemia, at least 10% on a nuclear stress test or the equivalent using different stress test modalities? Patients were, well, the question is, was it an invasive approach with optimal medical therapy plus cath and revascularization, or a conservative strategy of medical therapy alone? So we recruited patients who were stable from stress testing labs who were thought to have at least moderate ischemia as interpreted by site personnel. And those that had normal renal function and no known anatomy, so that their anatomy had not previously been defined, underwent a blinded coronary CT angiogram. And this enabled us to exclude patients who had left main disease, of whom there were 7.5%. And we found that a little over 20% had no obstructive disease. These patients were excluded, the left main, because of those early studies showing a survival benefit to patients who with left main who undergo revascularization. And we were able to exclude patients with no obstructive disease, thereby enriching our analytic cohort. So remaining were a little over 5,000 patients who were randomized to an invasive strategy of medical therapy, cardiac catheterization, and then the revascularization procedure of choice, depending on their anatomy, or the conservative strategy of initially medical therapy alone. We also excluded patients with an ejection fraction less than 35%, a GFR less than 30, a recent acute coronary syndrome, and severe valvular disease. Our primary endpoint was time to cardiovascular death, MI, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And our major secondary endpoints were time to cardiovascular death, or MI, and angina-related quality of life as determined by the Seattle Angina Questionnaire. We had a definition for optimal medical therapy that is basically consistent with the American College of Cardiology, American Heart Association guidelines for secondary prevention that include behavioral interventions, physiologic risk factor goals, and pharmacologic treatment targets. We had algorithms for that are very simple, how to treat using a stepped approach. We wanted everyone to be on a high intensity statin with the LDL goal of less than 70, and then to advance to ezetimibe, and even in some cases, PCSK9 inhibitor evolocumab to achieve that LDL goal. We began with a blood pressure goal of less than 140/90. That was revised later on when the guidelines changed to less than 130/80. And we had stepped pharmacologic therapy for treating angina. Here are some of the risk factors at baseline and at the last visit during the trial. The peach color is at baseline and the dark color at the last visit. You can see that essentially everyone was on a statin throughout the trial. High intensity statin use was about 40% at baseline and 2/3 at the last visit. ACE inhibitors, 2/3 going up to 70% by the end of the trial. At baseline, the LDL, the median LDL was 83, and at the last visit, it was 65. The percent who reached the LDL goal of less than 70 went from 32% at baseline to 59% at the last visit. the systolic blood pressure goal of less than 140 from 2/3 to 3/4. Virtually everyone was on antiplatelet therapy. You can see the small change, the small increase in non-smokers during the trial. This last set of bars refers to the proportion or the percent of patients who had achieved all 4 of these medical therapy goals, and that number doubled. But notice that achieving these relatively simple goals was achieved by only 41%, meaning that all of them were achieved in only 41% of our population. Here's the primary outcome measure, this 5-component composite. And you can see the cumulative incidence in the invasive strategy in red and in the conservative strategy in blue. And what stands out is that there was a relatively low event rate in this group with a lot of ischemia, and that there wasn't much difference between the conservative and invasive strategies. A magnified view of that figure shows that these curves were not parallel. They are crossing curves. There was a higher incidence of the primary outcome measure in the invasive strategy early on. The curves crossed at about 2 years. And then there were fewer events in the invasive strategy, but the time to an event overall was not significantly different between groups. That crossing curve phenomenon is explained by these 2 figures. The primary endpoint was driven by myocardial infarction. On the left-hand side, you see the incidence of procedural MIs during the trial, and not surprisingly, there were more procedural MIs that occurred as a result of the PCI or cabbage procedure. They occurred early on and remained more numerous in the invasive strategy. Interestingly, there were fewer spontaneous MIs in the invasive strategy in red compared with the conservative strategy. This difference started early in the trial and continued. These curves look like they continued to separate during the trial. And that explains, if you squish these curves together, why there were crossing curves with more events early on in the invasive strategy and more events later on in the conservative. The hardest endpoint of all is death. And there was absolutely no difference between the groups. There were 145 deaths in the invasive strategy, 144 in the conservative strategy. This forest plot shows the difference in event rates for various pre-specified subgroups. The event rates at 5 years, the estimated 5-year event rates in the invasive strategy are shown in this column, and the conservative in this, and this shows the difference. And you can see that the 95% confidence intervals all are touching 0, meaning that there was no significant difference between strategies for any of these subgroups. But I want to call your attention to the ischemia severity subgroups. And I want you to notice that as the severity of ischemia increased from mild to moderate to severe, there was not a corresponding increase in the risk of having an event. In other words, the severity of ischemia did not predict events. That's in contrast with anatomic severity. As we go from 1 vessel to 2 vessel to 3 vessel disease, there is a clear monotonic increase in risk, although that risk was not reduced by randomization to the invasive strategy. I'll briefly summarize the quality of life results by saying that for patients that had angina at baseline, the invasive strategy was superior. And the more angina people had at baseline, the greater the benefit. However, for patients who had no angina at baseline, there was no difference in the quality of life between the invasive and conservative strategy participants. So those are the results, and they raise some questions that we need to think about when we're taking care of patients. How should we diagnose obstructive coronary disease? A patient presents with a good story. What tests should we use to confirm that diagnosis? And do we need to rule out left main disease on everyone that has at least moderate ischemia on a stress test, since that's what we did in the trial? At what point should patients be sent to the cath lab and revascularize? And if that decision is driven by patient symptoms, how should we collect that information? So with regard to that question about how should we make the diagnosis, you've got a patient who complains of exertional chest pain. It sounds like a good story. Now, historically, and what our professional guidelines say in the choosing wisely, if the patient has an electrocardiogram that can be interpreted, that they should undergo a non-imaging exercise stress test. Usually it's a treadmill test. And the advantages of such an approach are this, compared with other stress tests, is less expensive, and you can evaluate the symptomatic response, the blood pressure response, the rhythm response to exercise. But you can't quantitate ischemia or localize ischemia, and these are things that I know most cardiologists like to do. I'll point out that the quantity of ischemia and the locality of ischemia, was it anterior, inferior, lateral, that didn't matter in terms of prognosis. But the main thing is that you can't rule out left main disease. And again, 7.5% of patients that had at least moderate ischemia on stress tests had left main disease in our cohort. So you could go with a stress imaging test. And the advantages are that you can quantitate and localize the ischemia, and you can use that test even if the ECG is not interpretable. It's more accurate at identifying patients who have ischemia, but it's more costly. In the case of nuclear stress tests, there's a fair amount of radiation, a lot of radiation. And again, you can't rule out left main disease. Or door number 3, should we go with coronary CT angiography? With that procedure, you can confirm whether or not obstructive disease is present. And again, anatomic burden is the predictor of events. It's not the severity of ischemia. You can rule out left main disease. So those patients should go to the cath lab based on what we know today. And you can even do non-invasive FFR to get an idea about the physiologic importance of an intermediate stenosis. You have to have good renal function in order to undergo the test. In some places, such as Stanford, it's very costly. But although I've put radiation as a disadvantage, it's only 1 millisievert these days, as opposed to, say, something in the 10 to 15 millisievert range for a nuclear stress test. And then, of course, there are some physicians who would argue that you should just go straight to cath. So I think that the lessons from the trial are that there's no need to rush people who are stable to the cath lab when you've made a diagnosis of obstructive coronary disease, that their prognosis depends on anatomy. And so I think that makes coronary CT angiography the best first test to evaluate suspected coronary disease. You could see from our risk factor results that we could do a lot better than we do. Here is the best situation. We have patients who volunteer to participate in the clinical trial, so they're motivated. We have algorithms to treat risk factors, and you have people like me who are calling sites saying, please prescribe a high intensity statin. And yet, that you saw what we were able to achieve. We could do a lot better, and I think that implementation science can help us lead the way in achieving better risk factor control. I think that we should use a validated measure to assess patient symptoms, and the Seattle Angina Questionnaire is the best method in my opinion, and that's what we used in the trial. So we have a plan with John Spertus, who ran our quality of life analysis and who developed the SAC. We have a plan to develop an app that patients and physicians can use in their shared decision-making encounters to collect the information and to figure out what that means in terms of their prognosis if they were to undergo revascularization or stay with conservative management. I think that we need to share evidence, especially evidence from this trial, with our patients and explain to them what they should expect to gain from a revascularization procedure. If they have angina and they're not satisfied with their quality of life despite optimal medical therapy, by all means, that's the patient who should undergo catheterization and revascularization. If the patient is asymptomatic, but for some reason they had a stress test or a coronary CT angiogram and you know they've got obstructive disease, it doesn't make sense to revascularize. There's no indication that their prognosis will improve. And so it just doesn't make sense to undergo the risk of the procedure and the cost of the procedure. So my last slide is something that I've worked on with John Spertus. You've got a patient with stable coronary disease. All these patients should undergo medical therapy or receive optimal medical therapy. I'll point out that during the course of the trial, PCSK9 inhibitors became available, icosapent ethyl became available, or we learned that it was effective in reducing events. The SGLT2 inhibitors and GLP-1 agonists, low-dose rivaroxaban, there's new evidence, even just in the short time since we did the trial, that improve outcomes with medical therapy, suggesting that it's going to be harder and harder to prove that revascularization improves clinical events. So the real question is, does the patient have left main disease? And if they do, they should undergo cath. And if they don't, with the help of the Seattle Angina Questionnaire, what I think should happen is that a shared decision-making meeting needs to go on with the clinician, taking into account the patient's values and what their preferences are about how they want to be treated. And if they're satisfied with their quality of life and they have no symptoms, then stay with the conservative approach. And if they're not satisfied, then a trip to the cath lab to undergo revascularization. Thanks for your attention. Thanks again to NHLBI. I want to also thank my partner in this, in conducting this trial, Judy Hockman at NYU, and the many other investigators. Thank you very much.
Thank you, David. That was terrific. I'm wondering, so the next thing on our agenda, we were going to have Bill Balmer talk a little bit about what this means to the clinician. Before we do that, maybe we should give David Goff an opportunity to say, if he wants to, how this fits into the NHLBI research agenda. And David, as a federal former NIH employee, I I know that you're restricted in things that you can and can't say, but is it possible for you to tell us a little bit about how the ISCHEMIA results figure into what you guys are thinking about future clinical trials and a research agenda?
Well, thanks, Bob. I think, yeah, these are personal opinions, so don't reflect, the DHHS, federal government, all that kind of stuff. But I would say that speaking, I've talked with Gary Gibbons about this, other institute leaders, we're very pleased to have been able to support this trial. We think this trial generated important evidence that's going to help clinicians take care of patients. We think the results, I tend to agree with David's interpretation of these results. If someone has, treatment refractory angina that is so troublesome, can't be resolved with optimal medical therapy, then it looks like, the more invasive strategy improves quality of life, reduces symptoms, but there's no rush to go there in people who don't have treatment refractory angina. So this is an example of a trial that we funded that was testing treatment strategies that were already being implemented in practice to try to determine what was better from, you might say, a comparative effectiveness approach. We're very interested in this sort of relevant research that's going to guide decision makers. And the decision makers in this case are patients and doctors and probably payers as well at some point. So, I think this was a successful use of taxpayers' funds personally.
Great. Well, thanks. So we're going to launch into the general discussion. So all of you out there that have questions for either Dr. Goff or Dr. Maron, now are we doing it through the chat or through the question and answer? Or maybe we can monitor both of them. But before we launch into the more general discussion, I wanted to introduce Bill Baumer. Bill is the statewide chairman for the Right Care Initiative, and that he has been very active in this group for quite some time. He is a practicing cardiologist at UC Davis, and that he's the director of the California EPCI program. He is just an extremely accomplished person. I won't go into that in a lot of detail, except to say that that we asked Bill if he would be willing to comment on the COURAGE and ISCHEMIA results and how that is affecting the practice of clinical cardiology in California. So, Bill?
Yes, thank you very much for that. I hope everyone can see the slide that I have up now that I'm sharing. That is related to the procedures that have been done in the state of California over the last 20 years. And if we look on the left, the gray arrow is pointing to a blue line, which is isolated coronary artery bypass grafts. And what we see is that blue line, since about 2000, over the last 20 years, there's been a gradual reduction in isolated CABG, which are the revascularizations for the angina patients that would be presumably similar to the ischemia group at some point. And what we see is in 2001, there was a gradual reduction in revascularizations in blue, but it was offset by an increase in revascularizations on the upper line in orange, which represents PCIs, or coronary stent interventions. You can see for the first 5 years of that period of time, there was a reduction in CABG, but it was offset by an increase in PCI. So literally just a shift from the OR to the cath lab for interventions. COURAGE was introduced in 2007, early in 2007. We had the results of that. And you can see that COURAGE showed a reduction in the state of California in the upper orange boxes of PCIs. These are elective PCIs that are done for individuals without acute coronary syndrome. So they're scheduled, mostly elective procedures. And you can see there's a gradual reduction from 2007 that goes down through 2013 or so. So I think what you see is at or shortly after the introduction of Courage, that in California, clinicians did observe or make themselves available of this information. And there was a significant reduction in elective PCIs for angina. And if we add the two of them, we can see that something like 60,000 revascularization cases eventually dropped to about half of that, approximately 30,000 if we add CABG and PCI at the end of the time of 2018 or 19. Now, what we don't yet have is the actual 2020 results, which were the second arrow shows the timing of the ischemia trial. So it's relatively new, and I don't think we'll be able to judge that immediately, especially since the data is overlaid by the COVID crisis, which has led to almost perhaps an independent reduction in some of the vascularization procedures. But what I think we do have evidence that over the last 20 years, there has been a significant reduction in revascularization procedures in the state of California. And some of that was associated with the release of the Courage trial, and we'll still have to look at it for the ischemia trial. So a reduction of about 50% that we see there. And the question that I have for, for David is, here are current recommendations. These were published in 2012, haven't been changed a lot at that point. And what they show is appropriate use criteria are seen with the letter A. And what you see is there's a lot of A's on the right on the graph or on the chart here, showing that there are individuals, including individuals with mild symptoms on minimal therapy, and on the lower part, asymptomatic patients, where it is still appropriate use criteria to perform coronary revascularizations. So my question for David is, in view of Courage and the trials since Courage, including ischemia, is it not time to reanalyze our appropriate use guidelines and perhaps make further changes in those as we look to the future for individuals who have mildly symptomatic or even asymptomatic coronary artery disease?
I assume that David, you're asking is Maron and not Goff? Okay,
well,
2 thumbs up.
We could do both. We could do both.
No, I totally agree. And I actually was on the writing committee for the appropriate use of for revascularization. And I'm quite sure that they're going to, the guidelines will be changed. They're in process. When I say guidelines, you know, whether we should do revascularization, and then the appropriate use criteria will be revised as well to incorporate this. Now, one of my greatest honors was that there was an editorial in the New England Journal that accompanied our papers, and it was written by Elliot Antman and Eugene Braunwald. And I think they say it very clearly that at any time along the way, if the patient is not satisfied with their quality of life, then they should undergo revascularization. The quality of life benefit was durable in the ischemia trial, as opposed to in the Courage trial when it seemed to expire. So yeah, I think that a reasonable attempt at medical therapy really should be made out of fairness to the patient and for societal concerns about the cost of healthcare. But I think that a patient who is symptomatic, not satisfied, they should undergo revascularization, have an attempt at revascularization.
And we have a bunch of questions that are starting to pop up, and one of them is from Angela Gambron, and the question is, what impact production and number of procedures would optimal medical care have on invasive surgeries for cardiovascular disease? So if you really were able to fine tune the medical care portion of it.
I guess I'll take a crack at that one. But anyone else who knows more, please speak up. Right off the top, about 25% of elective PCI are performed in patients who are asymptomatic. So, right there, hundreds of millions of dollars could be saved annually by deferring revascularization procedures. And then there's some evidence, and I'm not particularly, I don't know all the details, but there's some evidence that patients who undergo elective PCI for symptoms are actually not symptomatic. So, and that some patients who undergo PCI for unstable angina are stable. So it's called upcoding, and this phenomenon. And so there probably are a lot more procedures performed that don't really need to be performed, based on what we showed with Courage and what was shown by the Berry 2D investigators, and now with ischemia. So conservatively, hundreds of millions of dollars, tens of thousands of procedures could be prevented or saved.
Great. There's a question from David Goff, and maybe David wants to ask this himself, that it has to do with can CT, not CT angiography, for CAC scores. David, do you want to ask the question? The reason that this is a good question for this group is that the group has spent a lot of time talking about coronary calcium screening. And I saw Matt Budoff on the set of pictures here. I don't see him right now. I don't know if Matt's still with us or not, but
he's still there. He's walking around.
He's walking around. I'm sure Matt will have an opinion. But
He's on a call right now. You can see he's talking on his phone. Sorry. I think David Maron can probably weigh in on that. And here's Matt's back with us. Matt, can you unmute yourself, please?
Sorry, yes.
And
So Matt,
and Bob, you're going to have to rephrase it. Yeah.
Sorry, yes. Sorry.
Does coronary calcium have a chance of detecting left main disease?
Probably not reliably. It might work as well, almost as well as CT angio in this trial. In the PROMISE trial, calcium scoring and CT angiography were similar in their outcome prediction. So it may almost work as well, but not for left main specifically. It may predict future events though.
Yeah, I think that was the question that I had, was
Yeah.
that, a CAC scan is a even briefer and less exposure than a CTA. So if your strategy is someone who has suspected coronary disease, you're trying to rule out left main, would a CAC scan be sensitive enough that if there were no left main calcium observed, you could rule out significant left main and only go to CTA for those who had calcium in their left main area? Sounds like Matt's saying not sensitive enough. There'd be a a likelihood of having non-calcified left main stenosis or plaque big enough that you'd be concerned about it and want to do revascularization. That was the issue
I think
for me.
unless there's a score of 0, if the total score is 0, I think you can probably almost perfectly rule out left main, but not just left main calcium, but a total calcium score of 0, which is a portion of the population, but a smaller portion of the patients who we would evaluate. Yeah.
Yeah, small proportion. If that was your level to rule out, then it's not a very effective first test to do to avoid the additional radiation of a CTA, I think. So that was the reason I asked the question. So thanks.
So the next question comes from Jeff Thompson, and it's a question to everyone. And the question is, this is very important knowledge, but we're moving ahead at a good pace, but still making almost no progress at the distribution of care to poorly served areas in the country. What can be done to expand adoption and improved access? And Jeff, I see you on the screen. If you want to expand that.
No, I think that's pretty good. I really like the analogy early on about the fence at the top of the cliff. That was particularly telling. And I guess I'm probably the only pediatrician on here, but as the CEO of a health system, had a lot of cardiologists, a lot of internists, a lot of family medicine folks, and the ability to adopt to this great research. It's so important to do the research. I'm a big fan, but we have to figure out ways to adopt that, and then for people to get access to care in rural areas and inner city areas, the reservations, all those kinds of places. So I'm wondering, as you're building these studies, you're coming out with the information, where is our responsibility in saying, how then do we organize it so it can be adopted? How then do we use our power at the American College of Cardiology? It's a very important group. How does it get the NIH? It's a very important group. How do we get that so we actually can implement this across broad strokes of the communities that are not served by high-end, very astute cardiologists?
And it's worth saying that, so NHLBI and George Mensa does have this activity that is beginning to try to address this. But, again, my personal opinion, not as a formal NIH employee, but the coordination between federal agencies is not optimal. So the NIH is really the research-focused agency, although it has an increasing role in implementation science. AHRQ, again, is a separate, sister agency, but still a different agency. CMS is a different agency. And although there is discussion among these agencies, I feel it could be much better. I don't know if others have comments on that, but how do we get to that next level? And again, I want to comment just briefly, and David Goff can probably speak to this more clearly than I can, but I do think that Darwin-Labarth's national plan started to deal with these sorts of issues, because the plan was, again, on the prevention side, to try to develop a coalition that went not only across government agencies, but across American Heart Association, professional societies, and states and local health departments. I don't know, David Goff, do you have a comment on that, and how can we get better at this?
Yeah, well, again, speaking personally, there are so many targets. It's a target-rich environment, and so if you're talking about how can we get better at building implementation-ready structures. So we just recently reissued our cardiothoracic surgical trials network. Now, getting cardiothoracic surgeons to come together and agree on doing clinical trials together in a multi-center way is an amazing thing to do, because they're, often wrong but never uncertain, right? That's the surgeon's motto. So getting them to come together and agree to randomize patients and to randomize them to a common protocol, okay? So that was challenging enough in the first round. The most recent round, we required each site that was proposing to participate to come in with a less research intensive site as a partner, because in our networks, the rich get richer and the poor get left out, right? So a lot of the money from NIH goes to a handful of institutions around the country, and the less research intensive institutions don't get much. So we required these institutions who wanted to get a site in this network to bring in a low resource partner. That helps build infrastructure at some of the lower resourced academic centers around the country to do this kind of work and to be ready to implement this kind of work. That's a tip of the iceberg with respect to the issues you're talking about. So, like I said, it's a target-rich environment. So we're trying to partner with HRSA and their home visitation program at the other end of the spectrum to serve the needs of low-income women who are pregnant, delivering children, to focus on cardiovascular health promotion and linkage to community services and community practices and social work and all the things that are important to get the mother on a good trajectory for her cardiovascular health and the child on a good trajectory for his or her cardiovascular health. That's another, I mean, like I said, this is a target-rich environment. It's going to take all hands on deck. Getting the local health departments and state health departments better equipped to support cardiovascular disease. At one point, when we were putting this public health action plan together that Bob has referred to on several occasions, we contemplated, making cardiovascular events reportable events, because, every heart attack and stroke represents a failure of prevention. We believe, based on the evidence we have today, that we can prevent 80% or more of the cardiovascular events that occur in our country every year. That means 80% of these or more are failures of prevention, and that should be a national disgrace. And so, if we had this mindset that this is not just what happens, right? Heart disease just happens. If instead we had the mindset that every heart attack that happens is a failure of prevention and somebody's held accountable for that failure, we'd have a different situation. Again, I'm speaking personally. Over.
Okay, we have.
I just want to say that as a former regulator of the health plans of the state of California, I found it shocking the level of lack of awareness of the importance of preventing cardiovascular events. That my colleagues across state government didn't seem to understand the volume of difference of working on one topic versus another. So impressing upon regulators the law of large numbers that we're dealing with in cardiovascular disease might help. So if we, for instance, had a federal rule that said we need to prioritize money into the #1 killer and disabler, across cardiovascular diseases, whether it's heart attack or stroke or cardiovascular dementia, I think that would really help drive the funding and the priorities in regulation toward better cardiovascular prevention efforts. So right now, the dialogue in state government in the state of California is pretty much on not focused enough on getting the health systems to do what we are now capable of doing. So when we did the work together, Bob Kaplan and I, in San Diego, thanks to the grant from the National Heart, Lung, and Blood Institute to implement intensively in one place, if you see the graph behind my head in aqua, it shows a very rapid reduction in acute myocardial infarction hospitalizations simply by teaching the health systems in one community and using data to drive quality improvement to control cholesterol, blood pressure, and blood sugar for those that were already diagnosed. So we now have in the toolkit, like Dr. Maron was saying, so many new agents that are not being used. So people, a vast majority of the preventive measures are underutilizing the significant tools that we now have in the toolkit. So I think doing it would help the health systems if protocols were written saying exactly how do you use PCSK9s? Who are they for? How do you? We need to make it easy for the primary care physicians and the health systems to know specifically what to do. When they argue, well, PCSK9s are expensive, icosapent ethyl is expensive, it's like, yeah, compared to what? When I myself, as the daughter of a father who had quadruple bypass and a mother who died of a stroke at age 15, when I see health systems and I hear health systems, medical groups, medical directors from health plans or medical groups saying, well, those drugs are expensive. I have to say, you know, compared to losing a parent, an actively parenting adult in a child's life, the whole concept of they talk about adverse childhood events. How many children in America are completely traumatized by losing parents at a young age just because medication is not being properly distributed? So I just want to say, let's use our federal and state power to better protect families from this unnecessary devastation. And enough said. I think I have a lot of kindred spirits with me today, but I'm just so grateful that many of you are in a position to do something about this.
You know, just a quick comment, Jeff. You know, I know that you know this well, but others on the call might not be familiar with the complexity of California and other states that are, some of which are even more complex. But when I first met Hattie was working for the California Department of Managed Healthcare. So in California, we have these, individual insurance plans are regulated by the Department of Insurance. Managed healthcare plans are overseen by a completely different regulator. And that the original goal when Hattie first came to see me when I was at UCLA was we were going to try to get all these people together. So the idea was that we were going to get medical groups, insurers, patients, providers, and so forth in the same room to try to iron some of this out. And I think Hattie's done a good job of that over the last decade and a half, but it is pretty complicated.
Bob, I have a quick question for David Goff. And that is, you had a very impressive slide when you were looking at the stagnation that we had in cardiovascular events, initial reduction, now stagnating. And then to the right of that, you showed a map of the country, which was diverse as far as high prevalence areas versus low prevalence areas. Many of the recommendations that we come out with nationally, et cetera, are broad stroke. That is, we need to lower blood pressure in everyone. We need to do this in everyone. But it strikes me that there are individual differences within regions, and much as we do in medicine, clinical medicine, we're turning to personal.
Oops, Bill, you went on mute, Bill. Bill, you seem to be muted.
Bill, you're talking, but we can no longer hear you, I'm sorry to say. So I think Bill cannot hear me either.
Yeah.
So I think we should.
And they may,
Bill?
and they may be actually different.
Bill, you
Bill,
cut
we
out
just
for
had
quite
your audio.
Bill, you cut out for a period of time, but I think you were pointing to the geographic diversity and the idea that care might need to be tailored to the region as well as to the individual.
Right.
And that, yeah, and I think, that's right. I mean, I didn't go into some of the thoughts I have about why we have the geographic disparities we have, but I think we need to learn and try to understand why we have the geographic disparities we have, and then see what we can do about it. Now, if I were to show those slides, it won't surprise you to know that the highest cigarette consumption prevalence in the country mimics the slide I showed. The states with the weakest indoor air protections in terms of, if you look at the CDC's surveillance system for clean indoor air, smoke-free restaurants, bars, and workplaces, the states with the weakest protections pattern along with the states with the highest prevalence of cigarette smoking, pattern along with the states and the counties with the highest cardiovascular disease mortality rates. There's also strong evidence that statin utilization for secondary prevention is lower in these same areas. There's evidence that walkability within metro areas is lower in these same areas, the metro areas that exist in those areas. There's also some evidence from 10, 15 years ago, more so than now, that air quality measured by PM 2.5 was worse in these same areas than now. So poverty is much worse in those areas than in the areas with lower cardiovascular disease mortality. So there's a lot going on there to unpack. And we can certainly try to work together to change, you know, again, speaking personally, we can work together to try to change policy around indoor air quality. We can work to try to change policy around tobacco control. We know what works to reduce tobacco consumption. This is not an NHLBI research issue. This is a societal policy issue. We know a little bit about what promotes walkability and physical activity. We need to know more about that so we can be more effective in those areas. We know about grocery gaps, and we know about some things that help to address grocery gaps so that people can have access to healthy diets. And we need to do more research on how to get that better implemented. How do we get the DASH diet implemented widely across the country, or what people are calling plant-forward diets that are plant-enriched and lower in animal products? That's an implementation science kind of question that we could support in theory. Now, when we get to these issues that I think are really important around poverty, how do we address poverty? That's a big issue, and I'm not sure NHLBI can do that alone, right? NIH, maybe through a common fund program, could try to understand what are some of the interventions that are effective in improving the health of people in poverty. Now, other people might say, deal with the poverty, right? Address income, address housing. These are issues a little bit beyond the swim lane of NHLBI, but speaking as a former dean of a school of public health, I would say that, you know, those are really going to be areas that we as a society need to grapple with. But now I'm way out of my swim lane. So Bob, don't tell my boss what I just said.
I promise to be quiet. Okay, we have another question from Scott Flynn. Scott is a longtime leader in the Right Care Initiative, and Scott raises this interesting question. He said, if the guidelines change, hey, what are we going to do with all these treadmills? You know, can you trade them in for CT angiography machines?
I'll comment, but others on this panel may have some opinions to express as well. First of all, I don't think stress testing needs to disappear. As I mentioned, I think that for evaluating symptoms that maybe people feel dizzy when they exercise or get palpitations when they exercise. Stress testing is not going to go away. But I think that it doesn't really cost that much to do a CT angiogram. I had an interesting experience with a patient that I ended up referring to Matt Budoff to undergo CT angiography because the cost at Stanford was $10,000 or more to do a CT angiogram. And at Matt's lab, I think it was $880 or something like that. So I'm not really answering the question very well, but I think that stress tests will stick around, but I think that their use should be much less frequent. And I think CT angiography is the way to go with current technology. Any other opinions on that?
If not, oh, I'm sorry.
Oh, I just want a quick comment that this is very timely for me. I'm seeing patients today. I'm Evelyn Stock. I'm a preventive cardiologist at UCSF, and I've been working with the Right Cure Initiative for almost 2 years now. And this morning I had a wonderful patient who happens to be a very well-informed physician, which are, you know, our toughest and most wonderful patients at the same time. So he underwent a coronary calcium score and has a coronary calcium score of 600, mostly located in his LAD. And so we were talking about, you know, all of these measures and possibilities. And finally, we settled upon getting a CTA for him, you know, and it's good to hear this panel sort of conclude that that might be the best approach. We're lucky to have FFR measurements at UCSF, but we'll see what this shows. And if he doesn't have left main disease and doesn't have any other significant stenosis, he's, you know, completely asymptomatic, but very worried, rightly so. I guess one of my quick questions for Dr. Goff is, you know, we have a lot of information about what factors influence the development of coronary disease. And as you were saying, we don't have a lot of information about the preventative, active preventative ways of the factors that promote atherosclerosis, but we don't know what Uncle Herbert, who smoked and drank for 1 million years, yet died at 101, what are the factors that are protecting him? And I just want to say that if somehow we could get across the board, maybe a coronary calcium early in our population, how would that impact our overall survival and preventing, you know, everybody gets a mammogram, everybody gets a colon cancer screening. What are your thoughts around that?
So Dr. Stock, thank you so much for that question. There are a lot of different things that people have suggested in that space. So we had a workshop a year or two ago where I was certain we were going to come out of that with the idea that the time is right to do a clinical trial of CAC scoring to guide the delivery of clinical preventive services, like use of statins, maybe even use of antihypertensive agents, since the current guidelines say, you know, you should incorporate cardiovascular risk assessment in the use of antihypertensive agents. And so if you need to do a quantitative risk assessment, maybe CAC would help contribute to risk assessment. We didn't come out of it with that. Actually, there was a lot more interest in CTA than in CAC scoring, because the idea was we need to know, we need to identify CAC, we need to identify plaque earlier before calcification, because there may be a better opportunity to have reversal or actually cure atherosclerosis with identifying people before they have later complex calcified plaques. So that was a really interesting set of ideas that have come up, and that workshop report's been published, and there are probably people out there who are thinking about this sort of thing to try to identify in younger adults to use CTA rather than CAC scoring, because CAC, it tends to be negative even in men. Steve Sidney's on here, he can quote the Cardia data. You know, it's not very common in men before the 40s. It's not all that common in women before about the age of 50. For the most part, now people with type 1 diabetes, a different population, but in general, this is true. So if you really want to identify younger people where you might make a intervene early with some of these clinical preventive strategies and lifestyle change, you might need something more like CTA in that setting. Now, there's another group that's saying, no, you don't need imaging, you just need polygenic risk scores. And you can do these polygenic risk scores even at birth. So as part of newborn screening, you could identify newborns who, based on their polygenic risk score, had the same risk of developing atherosclerotic cardiovascular disease as people born with familial hypercholesterolemia. Well, and this is true. Now, if you wait until middle age to do polygenic risk scores, you really don't get much value over clinical risk factors, because most of the information has already been expressed through high cholesterol levels, high blood pressure levels, obesity, diabetes, and so forth. So if you're going to use polygenic risk scores, you probably have to go really early in life. But you can do that even earlier in life. And then you can reinforce the need for healthy behaviors, for avoiding smoking, for good diet and physical activity, and perhaps early use of medications to reduce risk in people who have a high polygenic risk score. You might not need to know what the specific genetic basis of the risk is, because it may be that a statin will be beneficial in people with a high polygenic risk, even if some of the mechanism isn't working through lipid metabolism, right? Or that blood pressure lowering may be useful in somebody with a high polygenic risk, even if it's not that their blood pressure is really, really high as a result of specific genetic risk. So these are interesting things. We need more research, but I think there's opportunity in the future to learn more about this and apply it. Thank you.
David,
I'd just like to follow up on what Evelyn said about some sort of a screening program that is reasonable for us to get started with. I come from a family with a lot of risk, and we have varied coronary calcium scores. Getting my coronary calcium score certainly shifted me rapidly to a plant-based diet, exercising every day, taking a high-dose statin, et cetera. But I have a family member with a score of over 1,000 who's doing all the healthy things and always has. So I just think it's, a godsend to have had the calcium score and to be taking proactive action with medication, optimal medication therapy management. But the idea that we have people walking around today that are 50 years old that have scores, coronary calcium scores of 1,000, really disturbs me. Now, I understand that Steve Sidney and Matt Budoff have done amazing work in this topic, and that the scanning program might need to be narrowed, not to do a general population. But I'd love to hear more thoughts on that. Dr. Sidney, would you care to unmute yourself? You are still muted. So how about you, Matt, since Steve is having trouble getting in?
So the question, Hattie, is just a practical screening approach?
Yeah, I mean, with David Maron saying that the CT angiogram is $10,000 at Stanford, and a coronary artery calcium scan at Stanford is $200. It seems like it's now the technology has improved to the point where we should be considering on a population level, just as we do for mammograms that kill, with breast cancer killing so many fewer people, we need to have a strategy on a population basis of how to use coronary artery calcium scans to get patients on optimal medication therapy management.
Well, I think the American College of Cardiology and American Heart Association have already put forth guidelines that I think are very prudent. Score of 0, you can delay therapy potentially depending on the patient. A high score, you want to intensify statin therapy. They talk about aspirin in the prevention guidelines. They talk about blood pressure control. So I think we have a strategy already that's been published and part of our guidelines. I think we need, more coverage, and I think we need better implementation. whether it's CTA, a low dose CTA angio, or a calcium score, we can debate, you know, the incremental cost and work versus the incremental benefit. But either one, I think, is better than the status quo, which are risk calculators that are just objectively not very good. I mean, I don't want to insult anybody, but they don't work well in populations that they've been evaluated in. So we need something better than the pooled risk equation.
So let me make a comment. Oh, I'm sorry, Steve.
Yeah, I think I'm unmuted now. Is that correct?
Yes.
Okay. Yeah, I was just going to add, and we've discussed it more than once, including with Dr. Rana's presentation at the last meeting, that you know, the CT scan, the coronary calcium scan, is good in conjunction with a cardiovascular risk score to kind of define better who might be at higher risk. And if you have a very low risk score, then you're going to have to do an awful lot of coronary calcium scans to have significant levels of calcification. And, you know, so I think the thinking is mostly going into these moderate risk score folks in terms of defining those who might benefit from further stratification with a CT scan. Also, as I, you know, mentioned at the last meeting, and I think last year when I, maybe not last year, but you know, a high risk score, even if you have a 0 CT scan, does not really get you off the hook. So you still have to treat high risk, you know, whatever the score is really, and showing that in cardio. And David, you may not know this because it's not published yet, and we've been sitting on it for a while. But there were people with high risk with a 0 score had a 20% chance, a 10-year chance of developing an event.
So, the comment I want to make, and it also goes back to David Goff, you know, so we do have a national strategy on screening, and that comes out of the United States Preventive Services Task Force. And, you know, we've talked about this in our group several times. And in fact, you know, David, we had Dr. Owen come and speak to the group, and Matt was there, and we talked about the differences between the USPSTF and the AHA-ACC on coronary calcium screening. And that what it really gets down to is, you know, looking at the evidence in different ways and the value of RCTs and what the outcome measures are and so forth. And the question that it raises, so USPSTF gives it an I for insufficient evidence. And that when I was at the NIH, that we were just getting into this idea that the eyes that come out of the task force should be a signal to NIH that we should be thinking about that as an area of investigation for clinical trial. So my question for you is, I know that the NHLBI can do a very limited number of big RCTs. So, you know, there's only one ischemia that comes around, you know, every, I don't know how many years. So how is it that you sort of assign the priorities to these research questions? And are you able to say anything about what you're thinking about this?
Well, thanks, Bob. I mean, we've done a lot of communication with the community. And so reaching out to the ACC and the AHA and the guideline writing groups to ask the guideline writing group chairs to give us information about what are the most important questions that need to be addressed to change guidelines based on uncertainty in the guidelines. And so we've gotten a list of ideas from them that we've put into our process and we think about. Leadership of ACC and AHA told us they were going to publish this. They have not yet. There's been some changeover in leadership at ACC, which may have contributed to that. But anyway, we're hopeful they'll eventually publish it. It's their work product, not ours. So we don't feel like we can post it on our website, even though we asked them for it. It's their work product. And specifically about coronary calcium screening, I was convinced that we were going to end up going down that road. Some of you may know that I was part of a team that put in an application before I went to NHLBI to do such a trial to test whether the use of coronary calcium screening in a subgroup, people in moderate risk, would be helpful in driving the use of preventive services, especially statin therapy, to improve outcomes. Matt was involved in that, as I recall, and there's probably others on the call who were involved, and we were not successful in getting that trial started. At this workshop that we had a former chair of the USPSTF as one of the workshop members, and the comment was made, yeah, we have the I classification there, but we also have a USPSTF recommendation that statins should be used when the risk of cardiovascular disease over a 10-year period is 10% or greater. You know, there's that recommendation. And so the advice to the group was that it could be sufficient to show that coronary calcium screening improves the precision of risk estimation and decision-making around that 10% threshold, and that an individual patient data meta-analysis could suffice as evidence to incorporate coronary calcium screening in the right subset to refine that risk threshold estimation. So that information's out there. People may be working on such individual patient data meta-analysis in order to address that issue. But the recommendation, we don't get recommendations from workshops officially, but the discussion at the workshop led us to conclude that we don't need a clinical trial of CAC screening at this point in time. We can kind of ignore that I and focus on the other recommendation as a way of considering the usefulness of CAC. On the other hand, at the same workshop, there was a lot of discussion of the potential value of CT angiography to identify people at risk at earlier stage when we may, because of a lot of the focus on residual risk. If you wait until people have calcified atherosclerosis, if you wait until people have clinical events, there's still a significant amount of residual risk even when you do things like treat with a statin and so forth. So the idea was, can you identify people who are on a bad trajectory earlier in life where you can intervene when there's less polypharmacy, when there may be fewer side effects, and you can intervene over a longer period of time and really, really drive down the risk of atherosclerotic cardiovascular disease by identifying those high-risk people early. And that's where we got into discussions of CTA and even discussions of polygenic risk scores. So that's the way we, kind of get input from the community, because this was community input. And we also, through workshops and through direct outreach to stakeholder groups like the ACC and the AHA and others.
Great. We're down to the last 5 minutes or so. So
Bob, could I?
Oh, yes. I was going to say, let's see if David Maron has anything in some regards. So.
Well, David, you may recall that I was at that workshop, and one of the suggestions that I made and was featured in that proceedings of the workshop was the idea of using an artificial intelligence algorithm that we've developed at Stanford to identify coronary calcification in CT scans, routine non-gated CT scans that have already been completed. There are maybe, according to Matt Budoff, close to 20 million of those done annually in the United States. And I think we're leaving information on the table that could be used to alert people about their risk. So an opportunistic screening rather than taking people who haven't had a test. I think that there's a lot of potential there, and more to come on that.
So I saw David G with his thumb up. So
thank you. Okay.
So David Goff, do you have any summary comments before we have to depart?
Well, thanks. This group is clearly doing great work and focused on the right issues to try to drive down cardiovascular disease and promote cardiovascular health. We're open for business. Most of the money that we give out to investigator-initiated awards. So people who are interested in topics like what David Maron just mentioned, write a good application, get a good score. We love to give money away. I keep telling people it's simple to get money from NHLBI. Write a good application, get a good score. I never said it was easy. It's simple. You know, and then it's all about implementation. So we need to figure out how to implement better. And that's something where we're supporting implementation science, but it takes groups like your group working in communities, takes, you know, the ACC and the AHA and public health and others. So I'm really heartened that there's a group like this working on these issues, the Right Care Initiative in California, that, you know, you're going to show the rest of the country how to do these things. These charts that Hattie has shared are so impressive. And I hope that you'll reach out to some of the less well-resourced states, you know, in your region and in the country to share your successes with those other states and show them the way forward. California leads the country on many things over the years. Hopefully this is another example of that. Thanks.
It's not just earthquakes and fires.
Sushi at the mall.
This has been terrific. I think it's been a wonderful session. I want to say that we didn't get to a question from Scott Flynn earlier. I think it was Scott that asked about the cardiovascular risk in the 0 to 5-year-olds. That turns out to be something that's been a big issue. You know, we worked on that a little bit when I was at AHRQ, because that there is this concern about do you test newborns and so forth, and their conclusion was you don't, but it's going to, I know, remain controversial. And when Darwin Labarth comes to visit with us in early January, this is his favorite topic, and that I think that his presentation is going to be about people not being born with cardiovascular risk and how they make that transition into risk categories and what we might be able to do about it. So Hattie, you're smiling, and we'll give you the final word.
Well, I wanted to really thank everyone who's participated today, especially the D squared, David Goff and David Maron. What a powerful team. And also just to invite you back more often, because it's this kind of discussion that really opens people's eyes. And the people who are participating today, many of them are medical directors of major health plans, increasingly around the country. So hearing this dialogue helps to bring to life the knowledge that many of you have. So Dr. Goff, because we were hoping that you and Darwin Labarth would be on the same agenda, and Darwin was not able to be with us today, perhaps you'll be able to join us again on Monday, January 11th. I'll check back with your staff, Zoe. And I'd like to invite all of you to join us for that date, but also we have coming up on Tuesday, the 24th, at our normal time of meeting at Stanford, a wonderful stroke program. And I'd really like to just encourage all of you to join us on Tuesday, November 24th from 4 to 6. We're going to be hearing from Jeffrey Saver, one of the nation's great stroke experts, and we're working with the California Department of Public Health on that program. So with that, it is past our 2:30 time, and I just want to say thank you, Bob Kaplan, for recruiting David Goff to be with us, and thanks everyone for keeping your minds open about how we drive down these 80% of the preventable cardiovascular events, and encourage you all to wear your masks and to get your flu shots, and please utilize the home blood pressure monitoring devices, because we need you all to take care of yourselves as well as your patients. So bless you all, and we'll see you on the 24th. Thank you so much, everyone.
Thank you.